Hello again. This is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight a paper of particular interest to the readership by interviewing one of the authors of an article from the February 2023 edition of the journal. The article I picked this month for more in-depth exposure is entitled, How to Provide Sexual and Reproductive Health Care for Patients, Focus groups with rheumatologists and rheumatology advanced practice providers by Dr. Daiva, Mitchell, and colleagues. I pronounced that okay? I'm not a good person. Today, I'm pleased to be speaking with Drs. Daiva Mitchell and Mehret Talabi, who will discuss the issues around sexual and reproductive health for patients with rheumatic disease. I want to thank you both for taking the time to speak to me and to our listeners. So let's begin. Could you briefly describe your previous work that led to undertaking the current study?
Sure, I'm happy to jump in there, and thank you so much for the opportunity to have this conversation today. Our team is really focused on trying to improve reproductive health care and therefore reproductive outcomes among people with rheumatic diseases. And we've conducted studies involving over 60,000 patients with autoimmune and rheumatic diseases using data sets such as Medicaid, IBM Market Scan, the American College of Rheumatology RISE registry, local data from our institution. And we've consistently found that females or people with childbearing capacity are not prescribed contraception, that it's rarely documented by rheumatologists, people's contraception use or non-use, even among people who use teratogenic medications that can cause congenital anomalies. We've also seen that people whose diseases are putting them at an exceptionally high risk of adverse pregnancy outcomes, such as systemic lupus, it's not controlled, or antiphospholipid antibody syndrome, are among the least likely to receive contraception. So we found this from our large epidemiologic studies, and we've done a deep dive with qualitative work with rheumatologists, where we asked them about their practices around family planning care. And we heard time and time again from rheumatologists that they don't have the time to address family planning with patients. And they don't really feel like they have the expertise. They don't have local resources like OB-GYNs to turn to. They're not familiar with contraceptive methods and their safety profile for patients with rheumatic diseases. So that work really provided a foundation for this study that we're going to be talking about. And we wanted in this study to hear from rheumatologists as well as rheumatology advanced practice providers, such as nurse practitioners and physician assistants, to hear their solutions to some of these barriers and challenges that we've been hearing about in our prior work. And I will just mention rheumatology advanced practice providers, or APPs, are in the United States providing a lot of rheumatology care to patients. We have a tremendous rheumatologist shortage here in the US, and APPs are providing rheumatology care to an increasing number of providers or patients. We wanted to include them as well.
Yeah, that makes sense. I mean, I think it's not only in the US, it's worldwide.
There you go.
Certainly, yeah, in Canada, we don't really have physician assistants for some reason. I think we may very well go to them, but we do certainly have nurse practitioners. And certainly for inflammatory arthritis, we have advanced practice physios who provide excellent care, so it's the same idea. Okay, anything you want to add, Dr. Mitchell? Okay.
No, you summarized it well.
So can you please review the methodology used in your study?
I will. I'm going to actually take a step back and describe
sure.
qualitative methods a little bit. I'm an epidemiologist by training, and my research team's general approach is to use epi methods and big data sets to highlight gaps in care, such as the ones I described to you that we've done, with thousands of patients. But the phenomena that we tend to see cannot fully be explained by big data sets. What is really happening on the ground sometimes can't be captured in large data sets. And that's when we turn to qualitative methods. And I just wanted to give you a little background about those because I think those are becoming more and more common in the literature. Qualitative research really aims to gather an in-depth understanding of a phenomenon of human behavior and experiences through interviews or focus groups. It comes from an anthropologic tradition rather than a quantitative tradition. So what one might notice is that in many qualitative studies, the size of the study, the sample size, the number of participants is smaller than what you would see in an epidemiologic study. But the idea is not to generalize one's responses. The idea is to really understand in depth, again, what's happening with a certain phenomenon. So it's a very rigorous research tradition, but it's different from quant-based research. The studies are often not hypothesis-based. You're supposed to go in without a preconceived notion of what you're going to find so that you're really listening to what people have to say rather than putting your own opinions and thoughts in the forefront. So in this study, we used qualitative methods and we performed focus groups with rheumatology providers. And we split our two groups up. So our rheumatology physicians engaged in focus groups, our rheumatology advanced practice providers were also in separate focus groups. And we decided to do that because we felt their challenges and barriers might be a little bit different. Some workforce studies here in the US suggest that our APPs have a little bit more time to spend with patients than do physicians. And as you know, time constraints were a major issue for rheumatology physicians in our prior work, we didn't want those practice differences to really kind of muddle our analysis or our results. So we turned to focus groups again. We did those virtually because of constraints related to the pandemic, but it also allowed us to reach a wider group of providers. And then we did a very rigorous coding process of the transcripts to elicit broader themes from what these providers were telling us about the solutions they felt that rheumatology professionals could use to overcome barriers and challenges to family planning care.
Anything like that?
No?
Okay, perfect. Yeah, I really appreciate that, you know, most people in medicine, as you said, come with the hypothesis-driven scientific method, not the what I see is more sociological based, just as rigorous. And I think that's the point that we need. It took me a while to get my head around that. I will admit that. But I've come to understand that it is a rigorous method, and I think it does appear more and more in the literature. So I really appreciate you explaining the rigor behind this.
If I can say this, Dr. Silverman, I had to learn, again, as an epidemiologist, I had to learn this entirely new way of doing research as well as a complement to what I was already doing.
Right.
It's a lot more expensive and it's a lot more time consuming. It's actually very easy when you have a clean data set to run some analyses on a weekend, you know, go in with a hypothesis and run an analysis and then you have, you know, your solutions. But if you're doing a rigorous qualitative study, it can take sometimes years to do a full analysis. So that being said, it is definitely very rigorous, and it takes a different level of time and, you know, in-depth analysis, I think, than some quantitative work.
No, thank you. Having said that, and you explained that you look for themes that emerge, and so perfect setup. So what major themes did emerge from the study?
Okay, I'll take this one. There were 4 major themes that emerged from our study, which I'll talk about the themes and then talk about a little bit of the background and details about them, how we came up with them. So the first thing was that rheumatology clinicians recommended preparing patients to engage in sexual reproductive health conversations before and during clinic visits. And the background of this theme really stems from the fact that clinicians believe that family planning goals are important to discuss with their patients. And this is sort of obvious, but obviously we care about their health and we want to help them live the life that they want to live, which also includes their sexual and reproductive healthcare goals. And therefore, planning ahead and collaborating with patients is very important to address their sexual and reproductive healthcare goals within the context of their rheumatologic disease, such as preparing for pregnancy during disease quiescent periods and ensuring their medications are pregnancy compatible as well. Yet, most of the clinicians also acknowledge that incorporating these family planning discussions within a 15, 20-minute clinic visit is difficult because of time restraints and other competing priorities. And therefore, clinicians recommended utilizing tools and methods to help prepare patients to have these discussions during the clinic visit in a more efficient and natural way. So one of the examples, which I'll talk about, specific solutions a little bit in the next question, but one of the major examples were things like pre-visit questionnaires, asking patients about their sexual and reproductive healthcare goals. And this allowed for both clinicians and patients to be prepared to have these conversations ahead of time, which, as I'm mentioning, can allow for things like more efficient conversations regarding their family planning goals. The second theme was that consultation systems are needed to facilitate rapid sexual and reproductive health care with women's health providers. And the context of this theme really stems from the fact that most rheumatologists believe that in order to provide the best care to their female patients with gestational capacity in the context of their rheumatologic disease, they need to have collaborative and multidisciplinary care with the other women healthcare providers, such as OB-GYNs. And this was especially true for things like contraception counseling and prescribing, which most rheumatologists and rheumatology APPs felt uncomfortable with. Yet most of these clinicians also stated that they didn't have these relationships with the women's healthcare provider to allow for these collaborative multidisciplinary care for their sexual and reproductive health care. And many circumstances can be somewhat time sensitive as well, such as when rheumatologists are prescribing teratogenic medication and patients aren't on reliable contraceptive methods. And therefore, clinicians are recommending building more rapid consultation systems with the women's health care providers to ensure patients get more timely women's health care. The third thing was that rheumatology clinicians advise development of training opportunities and easy to access resources to address sexual and reproductive healthcare knowledge gaps. The background of this theme is really that clinicians reported that they had their own knowledge gaps when it came to providing sexual and reproductive healthcare. And this was especially true around contraception and also medication safety during these reproductive transition points. And therefore, clinicians desired more training opportunities and education around these subjects through things like webinars or grand rounds, et cetera, that were specifically geared toward the sexual reproductive health care in the context of rheumatology. They also desired things like easy to access and streamlined resources that they could refer to when they're caring for their patients in the context specifically geared towards sexual and reproductive health care. They acknowledge they use things like the American College of Rheumatology websites or things like Otis Mother to Baby, but it can be sort of burdensome going from one website to the other, and a lot of them have logins. And so really finding ways to have more streamlined resources that are easy to access, they thought would be very helpful in providing sexual and reproductive health care. And the last thing was that rheumatology clinicians recommend that educational materials about sexual and reproductive health care in the context of rheumatology be provided for patients. And the context of this theme is really that a lot of the clinicians felt that their own patients had a knowledge gap when it came to their own healthcare and understanding their rheumatologic disease in the context of their own sexual and reproductive health care. And a few clinicians gave examples of where they were prescribing teratogenic medications, and despite what they thought was appropriate counseling and education. Still, patients ended up getting pregnant. Obviously, this is dangerous for patients and obviously the fetus. So these were very difficult circumstances, and therefore they desired things such as patient-centered education materials that were easy for patients to understand and have access to, and also easy for clinicians to access so that they could distribute them to their patients in a timely manner.
Anything you want to add, Dr. Talabi?
No, I think that was really
I think, you know, what strikes me when you say that it's specific, it's not specific. I mean, the theme really covers everything, every allied health professional that we require and that will require multidisciplinary clinics. You know, that's what just sort of jumps out at me. But I think one of the anecdotes I'll just pass on was a colleague of mine once said, so you can't get pregnant on, choose that wording, on cyclophosphamide. The patient comes back 3 months later, said, you were wrong, I could get pregnant. And I am. Again, watching that sometimes we don't have the time to really explain things and misunderstand size. But I think that, no, excellent. I think despite all that, I think we really do, this is so important to define what is missing. So that leads to the next question. So comment on the solutions. So I know I think you really did. Is there anything else you want to add to that?
I thought maybe I could give a little bit more specific examples
Sure.
Beyond.
Absolutely.
Yeah, so yeah, like we're alluding to, the themes and the solutions were one and the same, but some more specific examples. So the first solution, we're building tools to help prepare patients and clinicians to engage in sexual reproductive health care during the visit. And the most common example was the pre-visit questionnaires, which I already alluded to. And these would focus on asking patients things like their sexual activity, their desire for contraception, desire for pregnancy, anything like a need for an OB-GYN referral. This could be done in just giving patients paper before they go into a clinic visit, or it could be something like an app or something that both clinicians and the patients have access to. And then both parties are prepared to have these discussions. Most of the clinicians recommended doing this about every 6 months to ensure we were up to date on their family planning goals. The other example of this was creating reminders within the clinic, like a clinic poster that said something like, are you interested in becoming pregnant? Please talk to your healthcare provider. And this would allow for, if it was in theory pertinent to the patient, they would be more likely to bring it up. Both of these methods are just ways to prepare the patient to have these discussions in a clinic visit in a more natural, efficient way. The second solution was building these rapid consultation systems with women's healthcare providers, which one idea that many of the clinicians mentioned was building, relationships within a clinic of rheumatologists with another clinic of OB-GYN or MFM doctors. So they knew exactly who to refer to. So they had specific OB-GYN providers to refer their patients to. And then also they could collaborate with them throughout the process because they knew them and had this relationship with them. Other things were like automatic referrals within the EHR or electronic health record for patients who were not on contraception, but also on a teratogenic medication, or automatic referrals if you had some underlying high-risk features like antiphospholipid syndrome. Other ideas within this context too was incorporating dedicated APPs or nurses within the rheumatology clinic, like kind of what we're alluding to, multidisciplinary clinics that were dedicated to have these sexual and reproductive healthcare discussions and family planning with patients as well. Further, the third solution, which we talked about, were the training opportunities and easy to access resources centered on sexual reproductive healthcare for the clinicians. These training opportunities, like I sort of mentioned, webinars, maybe with like a certification at the end, was something clinicians were really interested in. Incorporating this within their grand rounds, or even incorporating it within the fellowship curriculum to ensure rheumatologists got exposure to this prior to practicing. And then also the streamlined resources, something like one single website focusing on evidence-based sexual reproductive healthcare was something that the clinicians were very interested in. And then the fourth solution is the developing of patient education materials for the focused on sexual reproductive healthcare for the patients. And this one's relatively obvious, but pamphlets, brochures that are easy to access for clinicians, and are patient-centered and easier for them to understand as well.
Sounds like 20 years worth of work. Sounds like somebody can have their whole career, two people at least.
What's great though is some of these solutions are so practical, and that's really why we wanted to go straight to the source. What are practical solutions that can be done easily? I mean, a practice can come up with its own brochure or intake questionnaire relatively easily to figure out how the workflow is going to go. You know, going into the electronic health record and putting prompts, et cetera, that might take a little more work, but a pamphlet or a brochure or a poster is low budget and I think pretty low hanging fruit. And so the solutions were varied, but some of them were very low budget, very easy to implement now. And some of them perhaps a little bit more aspirational, but you know, you can get there if you have a team that's interested and willing.
Excellent, thank you. So you'd mentioned that you did separate rheumatologists into groups and the rheumatology advanced care providers. I mean, for obvious reasons that they might have differences. In addition, I would suggest that the rheumatologists could dominate the conversations. But anyway, let's go back to the first point. Did they differ in responses? The themes, not on a minor level, but on a macro level? And were the differences, in your opinions, more pronounced between the groups or within the groups?
So I'll start answering this one. So in general, both the rheumatologists and rheumatology APPs voiced similar tools and ideas for implementing the sexual reproductive healthcare, and they all mentioned these four major themes. But rheumatologists seemed more interested in things like educational opportunities to grow in their knowledge about the sexual reproductive healthcare. So they were more interested in the webinars and things like grand rounds, et cetera. Versus the rheumatology advanced practice providers were a little bit more interested in things like EHR tools to help implement providing sexual reproductive health care to their patients. Examples of this would be like best practice alerts if a patient's on a teratogenic medication and they're not also on a contraception that's listed, or something like automatic referrals to OB-GYNs if they are in certain clinical circumstances. So they were more interested in these EHR tools to implement this.
That's interesting. And then the second part, was there generally within groups, like 70%, 80%, feelings of a lot of majority were coming up with the same answers, or was it rather diverse?
I would say it was diverse. Yeah, our analysis wasn't really set up to assess between group versus within group differences, but to Dr. Mitchell's point, there was considerable overlap in the responses between the two different provider groups. And one thing that I will mention is it's possible that gender makes a difference. All of the advanced practice providers who participated in the study identified as female.
Right.
Whereas it was roughly about 60% for the rheumatologists. And it's possible, and actually a number of the APPs mentioned that within their practice settings, because they were female, a lot of times young reproductive age women were referred to them, or, hey, can you talk to this patient about contraception? Because the rheumatologist, and from what they told us, the male rheumatologist in the group may feel less comfortable or knowledgeable about contraception and sort of assume that they had that competency. And sometimes they did, sometimes they didn't. But I wonder if some of the differences that we did see reflected some of those, not just the practice differences between APPs and physicians, but sort of who was part of our study. Again, a little bit difficult in a qualitative study to parcel those things out, but just something to consider when reading the manuscript.
Yeah, very good. And again, it's just similar of the solutions, as well as the themes. I think you really addressed that. So really it comes down to how do we then improve the provision of sexual and reproductive health patients? You outline great ideas. And how would you, I guess this is really hard, rank order your priorities? So if you were to start, what would you start with?
I'll take that. I would say that the house is on fire in the United States. Roe versus Wade was a Supreme Court decision in the US that provided federal protections for abortion care in the US. And it was overturned in June of 2022 in favor of Dobbs' decision, Dobbs versus Jackson Women's Health. And now we do not have federal protections for abortion access. States can individually essentially choose their stance on abortion access or lack thereof. And so I think what we're likely to see in the US at least are more pregnancies among patients with rheumatic diseases. And some of these pregnancies are going to be unwanted. Some of them are going to be medically ill-timed and occur when people's diseases are severely active. And some of them are going to occur when patients are prescribed teratogens. And in order to prevent these poor outcomes, I just want to emphasize, I think our practice as a subspecialty is going to have to change, and we're probably going to need to be more proactive and hands-on when it comes to addressing family planning and anticipatory sexual and reproductive health care for patients with rheumatic diseases. And, as our rheumatologists described, there are a number of barriers and challenges, but to your question, Dr. Silverman, I think the first thing we need to acknowledge is that we do have a role in providing some anticipatory sexual and reproductive health care to patients. I think acknowledging that responsibility is critically important. And I think, perhaps we as a subspecialty, and I'm speaking very broadly here, have been somewhat passive about this, kind of assuming that our OB-GYN colleagues or our internal medicine colleagues will deal with some of these issues. But I think because these diseases do have serious implications in some cases on pregnancy outcomes, as well as the medications that we prescribe in rheumatology and our core medications, methotrexate, mycophenolate, cyclophosphamide have been mentioned, can have fetal toxicity. We've got to be more involved. So I would just say, from my vantage point, when it comes to ranking what would be most effective or what would be most important for rheumatologists, I would say whatever you do, as long as you try to do something, would be better than not doing anything. At least acknowledging the responsibility, and whether it's putting a brochure in your clinic or whatever it is that can help you to operationalize some aspect of sexual and reproductive health care, I think it's needed. I think it's necessary. And I think it's going to really help, what really is a number of our patients who face these conditions.
Want to add anything, Dr. Mitchell?
I don't think so. The only thing I would add is that, alluding to what Dr. Talabi was saying, a lot of these solutions could be incorporated relatively easy. I mean, somebody would have to take some time and energy to do it, but things like these pre-visit questionnaires, just to get an idea before these clinic visits, would be something that would be not take a lot of time, energy, or money to implement. So some of these ideas I think could be implemented easier than others, but all of them I think could help in at least starting the discussion and engaging patients in this topic.
Thank you. One of the things that we've incorporated sort of into this clinic that I have as is using an electronic health record, which has questions directed right there. Are you sexually active in this? So what do you use? That is the simplest. Really, if you have an electronic health and you in your EMR or EHR, you have preset questions. This is a really easy one to add to at least bring the issue up.
You have to have the buy-in, you know, because people will just bypass the electronic health record questions if they don't really believe that it's their role to ask.
No, I understand.
Your point, you know,
100%.
We need to just get that buy-in because those tools are actually there. And in our manuscript, we mentioned a couple of resources that can be easily accessed by any rheumatologist, rheumatology APP, or you know, building their own competency in this area, or resources just for their own clinics and for their patients. So once you get the buy-in, I think some of those resources are actually out there. Some of them are already in electronic health records. We just need to be consistent when we use them.
I think that you hit right on with all these important issues of healthcare, that is rheumatology, with complex illnesses one has to deal with. I think it is very important for the women and men also have questions during childbearing age, that this has to be up there with cardiovascular health, et cetera, et cetera. I agree 100%. And we're lacking training. I come from a little different perspective. I come as a pediatrician, where in my lupus clinic, we actually have adolescent medicine people who see them on a regular basis, who address drugs, what is it, sex, health, and rock and roll, sex, drugs, and rock and roll, as they used to say, or as our adolescent medicine person says. But really, so they come prepared, and the mindset of the physicians is identical. You know, that those things are super important to adolescents and to young adults.
That's right.
No, excellent. So anything you want to add that maybe we missed? Okay, that was excellent. I agree 100%, but we have to get this in the forefront. And I really want to thank both of you for taking the time to review the findings and for a very good, and I hope thought-provoking discussion. And to reviewers and listeners, please read the manuscript, How to Provide Sexual and Reproductive Care to Patients, Focus Groups with Rheumatologists and Rheumatology Advanced Practice Providers, by Dr. Daiva, Mitchell, and colleagues, which is available for your reading on the journal's website, jrheum.org, and will appear in the February print edition. And I want to thank you all, including our guests, and hope you will join us next month when I speak to the author or authors of another article of particular interest. I'd like to also take the time to highlight that the March edition of the journal, in honor of the 50th anniversary of publication of the journal Rheumatology, we will be republishing 3 articles from the 1980s that I've deemed to be of importance to the practice of rheumatology. So thank you for listening, and hope to see you then or hear you then. Bye-bye.
Yeah.